شكرا جزيلا أستاذ دكتور هشام، eminent speaker, eminent title. جزاكم الله خيرا، وربنا ينفع بيك يا رب. معانا النكست سبيكر الدكتورة أروى حمدي، هتكلمنا على كيس برزنتيشن. بشكرك يا دكتورة أروى، اتفضلي، أهلا بيك.
Assalamu alaikum. I'm extremely grateful to be here today among my professors and colleagues. And I'm quite intimidated by this schedule sandwiching me between Professor Hisham Awad, our outstanding professor, and our amazing Professor Iman Ragab. Okay. Okay, our case is a newborn boy called Ahmed. Ahmed was born at a gestational age of 36 weeks. He's a third order of birth child of non-consanguineous Malaysian parents. On day 4 of life, Ahmed was admitted to a private NICU by neonatal jaundice. His level of photo was 14.5 and he came in with 15.5 milligram per deciliter. On examination, he had mongoloid facies, semian crease, wide separation between big toe and other toes, so Down syndrome was suspected, indicating the need for karyotyping. His initial lab showed total leukocytic count of 39,000. Neutrophils were 13, lymphocytes 20, hemoglobin 15.8 milligram per deciliter, and platelet count of 132. The baby's blood group was O positive. At this time, we did not have the red cell count. Baby's blood group was O positive, mother's blood group was A positive, and C-reactive protein was negative. The patient was placed on phototherapy. On day 7 of life, day 3 of his admission, he developed worsening respiratory distress necessitating non-invasive ventilation, CPAP. His chest X-ray was done and it showed cardiomegaly. His ABG showed respiratory acidosis with pH 7.25, CO2 69, and bicarb of 27. And his echo showed ASD, BDA with mild to moderate pericardial effusion. This was his X-ray. His new lab workup was done and showed total leukocytic count of 44,000 with appearance of peripheral myeloblast 39%. His hemoglobin was 17.5 milligram per deciliter with platelet count of 60,000. C-reactive protein was positive and his total bilirubin was decreasing. A thyroid profile done at day 7 of life showed that he had hypothyroidism with TSH 55.7, free T3 2.3, free T4 was 1.2 milligram per deciliter. These his labs showing at day 5, day 7, and day 9. CRP started to be positive. Total leukocytic count was around 30 to 40 with blasts appearing in the peripheral blood. His hemoglobin was around 15, 17. Platelets was dropping and he needed transfusion on day 9 of life. His INR was 1 and his BTT was 36. Regarding his antibiotics therapy, Ahmed was initially on ampicillin and gentamicin that were then shifted to amoxicillin and cefoperazone on the increase of the CRP, with the increase of CRP. On day 10 of life, his respiratory distress worsened and he started to have frequent desaturations for which he needed invasive ventilation. His ABG again showed respiratory acidosis. He was ventilated on SIMV pressure control with BIP 16, beep 6, and rate 50. And then the patient was transferred to our unit. On admission, he had very bad general condition with disturbed level of consciousness. His capillary filling time was 4 seconds. Systemic examination revealed chest was bilateral, decreased air entry with fine crypts all over. His heart, S1 and S2 were normally heard with systolic murmur. Abdominal examination showed hepatomegaly, splenomegaly. His vital data, heart rate 136, blood pressure 70/40, temperature 37, and ABG on admission was okay. pH 7.25, CO2 50, bicarb 19.5. At this point, he was on Dopiotorex on 10 mg per kg per minute, Lasix on 2 mg per kg per day, and Aldacton 2 mg per kg per day, and Profen was started. This is his X-ray on admission. In our unit, his CRP was 113, with total leukocytic counts 26, with 35 plots again showing easily in the blood, in the peripheral blood smear. Hemoglobin was 9, so he needed transfusion. Platelets were 112, and that was after transfusion that he received in our unit. creatinine was 0.9, his electrolytes, sodium was 128, and potassium was 5.3, his LDH was high, 1,179, his INR was 2.7, and his PTT was 55. He required high-frequency oscillatory ventilation, received irradiated bagged red blood cells on 10 cc per kg, and his inotropes were titrated as needed, guided by his general condition, by his perfusion, urine output, and blood pressure. He was started on Marinum, vancomycin, and amikacin. So our baby was, at this point, a newborn with features of Down syndrome, with peripheral blasts, with anemia and thrombocytopenia. He had hepatosplenomegaly and pericardial effusion, and he had hypothyroidism. Our active problems in the baby were cardiac consultation for possible pericardiocentesis, and our cardiology team decided against going for pericardiocentesis since his effusion was turning from moderate to mild, and abnormal thyroid function, on which he started L-Traxone, hemato-oncological consultation, and karyotyping with genetic consultation. Professor Iman Ragab was, this case was presented to her, and she agreed that it caused with the diagnosis of transient myeloproliferative disorder, in which we define, in which it is defined in the early 90 days or first 3 months of life by initial presentation with a blast that could be at any, that could be more than 5 non-erythroid bone marrow blasts in peripheral blood, and it should be together with either one of these. Verification was a second sample that shows also blast, and this was repeatedly seen in our patient. More than 5% non-erythroid bone marrow blasts, hepatomegaly and or splenomegaly, lymphadenopathy, and effusions, cardiac or pleural. And we had 4 of them in our patient. Therapy was recommended to be started according to this flow chart. Blasts, we had more than 10%, and we had a life-threatening, we looked for an evidence of life-threatening symptoms, which included here, the positive ones were hepatosplenomegaly and pericardial effusion. So it was agreed to start on low-dose cytarabine. He was started on low-dose cytarabine infusion as he had the criteria for the intervention, and cytogenetics on peripheral blood were to be sent. Unfortunately, later that day, he developed an attack of bradycardia and arrested, and did not respond to resuscitation. For us to be eliminated about this subject, Professor Iman Ragab will be joining us in her next talk. Thank you.
Thank you so much أروى. الحقيقة قلت لنا الحالة بطريقة مسلسلة لطيفة، وفعلا احنا أكيد كل شوية لازم هنتعلم معلومة جديدة. ولما بيقولوا إن في حد اسمه سفير فوق العادة، سفير فوق العادة ده مش السفير العادي اللي هو بيروح ما بين البلاد، لا، سفير فوق العادة ده بيطلبوه في الإمرجنسي عشان يحل مشكلة جامدة قوي زي سد النهضة، زي حاجة. فهي برضو إيمان هي سفير فوق العادة. الحقيقة دايما وأنا في كل وقت بقدم فيه الأستاذة الدكتورة إيمان رجب، بقول هي شهادتي مجروحة، لأن هي يعني إحدى بناتي اللي أنا بعتز قوي 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 بوجودهم في حياتي، وبعتز قوي يعني بناتي ده، لا هي بناتي بالسن بس، لا هي بس بناتي بالسن، لا بس هي الحقيقة قامة وقيمة وإضافة، ووجودها معانا في وحدة أمراض الدم والأورام indispensable، ما نقدرش نستغنى عنه، لأن هي يعني كثيرا ما تدلي بدلوها في أو بدلوها في الأمراض الدم، وأعتقد أن هي خير من يمثلنا، سفير فوق العادة. أستاذة الدكتورة إيمان تعلق على الحاجة.
بسم الله الرحمن الرحيم. يعني أقول إيه بس مش عارف. يعني thank you for the very kind and mood elevator. وحضرتك عارفة Professor Galila is my mentor, my supporter, and يعني